was really hard to put all of this in this long title. I tried my best. So it's an unusual presentation of acute interstitial nephritis, progressing to end-stage renal disease in an immunocompetent patient. So we had a 78-year-old female, history of coronary artery disease, hypertension, and asthma. She presented with fatigue, abdominal pain, diarrhea, and decreased urine output. This is all what's going on for 3 days. And then she had recently returned from France. She thought she had overexerted herself in heat. Now, pertinent negatives, symptoms: no fever, chills, shortness of breath, dizziness, chest pain, no constipation or blood in stool. Considering her urine output went down, we wanted to make sure no urinary symptoms. She denied any frequency, urgency, burning during urination. Her vitals were pretty much normal, setting bowel and room air. Physical exam, again, benign, focusing on abdominal pain, abdominal exam, bowel sounds positive, no tenderness or distension. But just generally, she appeared really ill. I put in the positive, again, positive labs. So you can see she was hyponatremic, BU and creatinine 79, and creatinine 8.3. So her at baseline, she was normal. It was normal creatinine. You can see all the liver enzymes, alkaline phosphate, AST, LT, all elevated. Again, baseline used to be normal for her. So these are all new for her. Believe is normal, myeloleucocytosis, and anemia. So logically, we ordered some of the tests, including CT abdomen pelvis, that revealed some sigmoid wall thickening. And then we also find liver abscesses. So for liver abscesses, we drained them, it grew Streptococcus intermedius. And then the blood culture also turned positive for Streptococcus bacteria. We followed up the bacteremia, wanted to make sure there's no vegetation, so echo was negative. For liver abscesses and the liver enzymes that were elevated, we actually got the hepatitis panel, autoimmune panel, that was all negative. Now, finally, it was a renal biopsy, also confirmed an acute interstitial nephritis. So unfortunately, she has a lot of diagnoses going on at the same time. We found Intermedius bacteremia, acute interstitial nephritis, and then we also saw the liver abscesses. So she was started on IV ceftriaxone, metronidazole, as well as steroids. Unfortunately, she became anuric, needed emergent hemodialysis, and then she remained on dialysis without any recovery throughout the hospital stay. She did clinically improve, was eventually discharged on 2 weeks of oral cefuroximine 100 milligrams daily and metronidazole 500 milligrams TID. And she continued to stay on dialysis and followed up with infectious disease. We made sure we schedule her for colonoscopy, and the reason is Streptococcus intermedius is also known to cause colon cancer. So the bacteremia alone, and she was anemic, we wanted to make sure she get colonoscopy out. Now, a little bit about Streptococcus intermedius. So this is part of Streptococcus endodosus group. So it's a normal part of all the GI flora, genitourinary, and GI tracts. And it's very infrequent pathogen. So when it does cause infection, it's usually separative infection, as we saw in the liver abscesses in our case. Now, when it comes to AIN, infection-related AIN, in our case was Streptococcus Streptococcus intermedius. So this is treated by treating the underlying infection, and then the steroid role is unclear. Usually, we treat AIN with steroids, but here the focus is to treat the infection. And how does that AIN happen? We have high metabolic demand, decreased blood supply that makes the tubular interstitium more susceptible for injury. So some take-home points. Infection-associated AIN is underdiagnosed, and our patients' progression to ESRD despite treatment highlights the importance of high index of suspicion. This case was very challenging, considering this is very uncommon etiology of AIN and rapid progression of ESRD leading hemodialysis. These are my references. And that's the last slide. You guys have any questions?
Question about, it looked like on your CT image, the patient received IV contrast material. How much do you think that contributed to her leading to end-stage renal disease?
So the contrast, I don't, because even after the contrast, I think it was very limited. And the reason we say that she was already getting fluid, so she was already in the part. And initially when she came in, it was already high enough that we were like,
So it went increase, yeah.
yeah.
And you were local before or after the I guess IR breakups.
So that grew almost around the same time, but the liver abscess were drained first, considering her liver enzymes kind of going uptrending. So we wanted to, but the treatment was pretty much parallel. We would have jumped regardless, one or the other. If we found abscess with Streptococcus Intermedius, we started the same antibiotics or the Bacteremia. So we were really on top of the treatment. Any questions? No? Okay, thank you. Well, I do want to thank all of my mentors and my faculty members who actually helped me take care of this patient. And also my mentors, Dr. Usha, Anand, and Dr. Rabia and Dr. Waldon, Garriss, who's here in person. So I appreciate that. Thank you guys.